But today we'll be kind of looking at the clinical practice guidelines that were recently released, I believe around February, changing the maintenance IV fluids in children, and obviously in the hospital setting. I don't have any relevant affiliations, or no one's paying me to do this. So, and then here's the objectives that were released earlier. You guys can kind of read through them. We'll kind of go over some epidemiologic principles. We'll work through the guidelines, then kind of review and summarize everything at the end. So our clinical question that the clinical guideline looked to answer with the PICO-TT format is our children 28 days to 18 years of life. Intervention was the use of isotonic maintenance fluids. So their big one was normal saline versus half normal or quarter normal, with the comparison being the hypotonic fluids, so like D5 half normal, that a lot of people are familiar with using on the floor. Outcomes that we were looking for would be any iatrogenic hyponatremia, and the type of question is therapeutic, as we're doing a therapy. And our type of study, it's a clinical guideline, and that is based on a systematic review. So why do this systematic review? There was some randomized control trials that had been done in a couple centers showing that there was some hyponatremia, and there was a question if it was linked to hypotonic IV fluids. And as more of these randomized control trials came out, they were looking for any risk with hyponatremia with hypotonic fluids versus isotonic fluids. So some methods. This was started by the American Academy of Pediatrics, and they formed a subcommittee to basically carry out the meta-analysis and then make the clinical guidelines. And they spaced it out over multiple specialists. They had intensivists, general practitioners. They even had what they called an expert in quality improvement, hospitalists, surgery, anesthesia, basically anybody that was involved with hospitalized pediatric populations, they put in on this subcommittee. So for our methods, initially there was a few meta-analyses or systematic reviews that were out there looking at about, there's about 7, and they all kind of looked at a lot of the same studies and analyzed these randomized controlled trials of maintenance IV fluids. So they took a lot of the search criteria from that and kind of rolled it into a big kind of amalgamation of all the search criteria that they liked, and then did another search through PubMed, the Cumulative Index to Nursing and Allied Health Literature, and then the Cochrane database. And all told, it yielded about 18 studies, 18 clinical trials of kids aged 28 to 18 years, and they ranged it time-wise from 2013 up to March 15th, 2016 was the cutoff. A total of the 17 randomized control trials were taken. There was some bias in one of them, so they got dropped off. And the total population of the study was about 2,313 patients. The studies were then evaluated by 3 independent reviewers from this subcommittee that they formed. They kind of worked through it like we do on our CAT forms when we do journal club. They did this critical appraisal, basically worksheet that they read the full text of everything. It wasn't just a review of abstracts. And then worked their way through that. And then they created forest plots using the random effects models and Mantel-Hazel statistics, and we're going to go through all of that as we get into it. And with their outcome of interest being hyponatremia on IV fluids. So they also analyzed everything for bias. As I told you, one of them got removed due to having high bias, and they used the Cochrane Handbook Risk of Bias assessment framework, and they basically plugged them all into this, analyzed them for bias. And as you can see, most of them are pretty low bias kind of across the board, but there was one that was high across the board, so they decided to nix that one. Inclusion criteria, it had to have patients that were 28 days old to 18 years of age, and general pediatric patients. They could be ICU patients. They could also be surgical post-op patients needing fluids. So you might think that seems like a pretty broad inclusion criteria until we get to their exclusion criteria. This is what the guidelines do not apply to. So any neurosurgical patient, anyone with congenital or acquired cardiac disease, any form of hepatic disease, any form of cancer, renal dysfunction, diabetes insipidus, voluminous diarrhea. They didn't quite specify what that was. I think they just kind of left it up to the clinician. So I assume if you're putting somebody on like one-to-one replacement, probably going to be voluminous diarrhea and would be excluded from this. Severe burns, neonates younger than 28 days, and then obviously because of that, our NICU babies. So the fluids that were looked at in the study, we kind of have human plasma up at the top so you can get kind of your reference range. Also, if you're familiar with your BMPs, your normal ranges, all that, we can look at that. And what they considered hypotonic solutions was going to be your D5.2% NaCl or your quarter normal saline, and that has a sodium equivalent of about 34 milliequivalents. Then you get your D5 half here, which is about 77 milliequivalents of sodium. And then the other three listed below are ones that they consider to be isotonic or near isotonic solutions. So your D5 normal, this is about 154 milliequivalents of sodium. They also have lactated ringers listed, which is 130. They did exclude, they didn't make any recommendations at the end on lactated ringers, so they kind of excluded that from their guideline. And that may just be because it's listed as 130, which would be not quite physiologic level. And then they also looked at plasmolite, which is another kind of near physiologic fluid, which is about 140 milliequivalents of sodium. So those are all the ones they looked at in the study. All right, so a little epidemiologic teaching point. What is a systematic review? And we kind of use them interchangeably, meta-analysis, systematic review. But it's a large pooled study. It reviews similar studies that have similar interventions looking at similar outcomes. And the goal is to generate stronger evidence than any kind of one single study. So you can kind of think of it as it's stronger than the sum of its parts. If you have a stack of studies and you say, look, I have all this great evidence, the meta-analysis is still going to be stronger because it takes all of that and then reanalyzes it, looks for any bias, any conflicts in the study, and then gives you kind of a good sample of population. And one drawback is it does rely on studies being done. So if it's a relatively new concept, something that hasn't had a lot of evidence or study out there, your meta-analysis may not be as strong. This is kind of our pyramid of quality of evidence or strength of evidence. So starting down here is your expert opinion, your anecdotal evidence, your case series, and then at the top of this unfiltered information, you'll see randomized control trials. This is, when they say unfiltered information, this is your primary studies. The researchers kind of reporting it directly to you, and then these are the reviews up at the top, where you take all of these. You can use meta-analysis of cohorts, meta-analysis of systematic or of randomized control trials. Obviously, randomized control trials being the ones that we would like, and then that being kind of your quality of evidence. And then probably somewhere down here at the bottom that they left out would be like mommy groups, Facebook, Google, all that good stuff. So we want to keep it up here at the top, so that's what we're looking at today. Alrighty. So this is the forest plots and getting into some more kind of in the weeds with epidemiology that I was kind of warning you about. But these are all of the studies here on the left listed. And then we have it broken down into your isotonic fluids, your hypotonic fluids here, and then your event. With our event that we looked for was hyponatremia, and then your total patients in each study. So as we kind of scroll down here, you'll see about 107 patients had isotonic fluids, but also had hyponatremia out of 1,100 total. And then in the hypotonic, they were on hypotonic fluids, and you see there's more patients here that ended up having hyponatremia. And what they called hyponatremia for this plot was anything less than 135 at any time during their hospital stay. And that was out of about 1,200 patients. So you can see it's pretty split down the middle. They had a pretty even number on each side. And then you get to this next column, which is weight. They assign weight to each study to see kind of how important it should be, how much it should sway the results and the guidelines. And a lot of that is going to be based on population size. So you'll see here this study here, population of about 12, and that's about 2.4. And that's represented over here by this tiny little dot, little square. And for the visual learners like myself, the bigger the square, the higher the weight. So you can kind of take a quick look at it, and it's a nice look just for a quick glance at the results. And they also put a risk ratio for each one. showing basically your risk of hyponatremia on if you're favoring hypotonic or favoring isotonic fluids, and if you're less than 1, you're going to favor the isotonic fluids, and if you're more than 1, you're going to favor hypotonic. And that you can also see being over here as they're all left of this line, left of 1. So this 1 is kind of the line of no effect here in the middle, and you can see a lot of them are following here on the left side, and we just have one study here with a pretty low power of about 0.7% that was on the other side of the line of no effect. And you can see kind of this is all the averages down here. So out of all of them, the average risk is that they are favoring normal saline versus or isotonic fluids versus hypotonic. And then this down here, as we get to, is going to be basically your mean point. So the summary of all these blue boxes and powers and risk ratios all right there, showing that general results all favor your isotonic fluids. Now this other number that's highlighted here is another concept we'll dig into. This is called heterogeneity, or kind of variance between the studies. This is about 14%. We have another table later on that shows where we want that to be. Generally, anywhere under 25% is a pretty good level of variance. Ideally, you'd have it be 0%, but that's usually in a perfect world. And a lot of times that would be with studies that they decide they're going to do this multi-center trial. They give strict guidelines of this is how you're going to do it, this is what we're going to do for the study, send it out to everybody so all the studies are the same. Ours was not. Ours was they just took randomized controlled trials throughout, and so we get some variance there. But it's still under 25%, so we're still pretty happy with that. Then the other concept here is, just to throw you for a loop, is this p-value here. You look and you see that's pretty big, and everything that you remember from step 1 says it's not 0.05. I don't like that p-value. I don't know what it means, but I don't like it. So what this means is that the variance or the heterogeneity in there is not significant, which is a good thing. So it's not clinically significant, which means that there's not a ton of variance in the study. So this is the only time, talking with Dr. Jaimes last night, this is the only time that we want our p-value to be not significant. So we'll kind of keep an eye on those as we go through some more tables. And then these are just the study populations showing the events. So this is known as a forest plot that we just looked at. Just to kind of summarize, it's a quick graphical representation showing variance, showing all the data from the study, and kind of the main outcome that we're looking for. How to read it, just like we talked about. If it crosses the line, there's no effect. And if it's completely right or completely left, then you're good. So that's, if it was all the way to the right, we would be saying we still use D5 half, we don't need to worry about it. And then anybody that's been on the floor lately knows that it favored left, and we are using D5 normal. So then the two types of modeling that you would do to generate these would be fixed effect versus random effect, and there's kind of reasons that you would use each one. So starting off, fixed effect, this looks at seeing the studies kind of as the entire population. It's only looking at your studies. It assumes there's really no population, no other patients outside of just the ones in your study. Whereas random effect, it looks at taking the studies just as a random sample of the population. So, it kind of gives you more of a broad range. It's more applicable to more people. And then fixed effects can estimate the effects or outcomes just in the group of studies. So it'll say, these are all the outcomes from the studies. This is your effect for the studies. We can't really generalize it or apply it to anyone outside of this. And then ours, like I said, it's kind of applicable to more people. You can apply it to the general population. And our study, as I said, kind of used ICU, post-op, some patients below 28 days, some, so it has a good range of variance. And kind of continuing on, fixed effect will actually assign more weight to the larger population studies, and you end up kind of losing any data that you would get from the small studies. They're kind of overshadowed by this. So larger kind of well-designed studies will eclipse them, and these smaller studies may show some untrue effects. So, we had that one study that had a weight of about 0.7%, and it showed, no, we should be using hypotonic fluids. So if we put that in fixed, it might have eclipsed that, not really shown that effect at all. Whereas random, you would assign less weight to population size, so the smaller studies can exert more of an effect. But with this, you get some, like an outlier effect almost. So if you have a small study with a small population, but it's showing that, yes, there's absolutely an outcome, and then the study that has 3,000 patients says there's no outcome, looking at the two, your understanding of epidemiology is, I'm going to believe the one that has 3,000 patients, but then this might skew your graph one way or the other, skew your results to favor these smaller trials that may not have a true study or not. And then fixed. So generally, if your variance, your heterogeneity is low, both fixed and random should give you pretty much the exact same graph. They should look pretty close. And as I said, it'll only look at the variance in between the two studies. Whereas random, high heterogeneity will give you really large, wide confidence intervals, and it's going to be more likely to show no effect. It kind of favors this null hypothesis. And it looks at variance between the studies and also in the studies themselves. So since our studies are pretty broad, they came from different centers, they came with different guidelines, different patient populations, that would be helpful. So make sure everyone's kind of paying attention to apply the concept a little bit. We'll take a peek at, we'll go back up here, look at our forest plot again. Which model do you think would be more appropriate to use in our study, this fixed modeling or this random effects modeling? We can do show of hands because nobody really likes talking during these. So we'll do who wants fixed modeling. Just raise your hand if that sounds like a good idea. And then who wants random modeling? All right, and then a good amount of abstentions. So, all right, we're doing well. All right, and then these are just some graphical representations that help me understand it a little bit. This is going to be your variability here. So if you have significant variability and you take fixed, it's going to make tiny little confidence intervals. It's going to make you think that you're really, you can put a lot of weight in that. But if you have random, it gives you these kind of wide confidence intervals, kind of hedging your bets a little more. And then this is the representation here. If they're kind of about the same variability-wise, fixed and random is not really going to matter a whole lot. Over here, this just shows that your random is going to give you much wider confidence intervals than your fixed will as well. So this is the variability or the I-squared value that we were looking at. This came out of a fairly sarcastic epidemiology textbook, so I really enjoyed it. But 0% is no worries. We like that. We want it to have no variability between studies. And then I told you before, 25% is where we're going to really draw that line. Once we start getting up there, the book says we should be getting concerned. We should be very concerned. And if we're at 100% variability, the studies aren't related. We're probably looking at like pediatric, adult medicine, and vet medicine all in the same study. And it says, why are we doing this study at all? So here's another forest plot. They kind of pared it down and did a couple variations of it to show us different effects. This forest plot here, they considered hypotonic fluids to only be the ones less than 70. So this is going to be your D5 third and your D5 quarter normal saline. And that's what they included here as your hypotonics. And your isotonics were your normal saline again. So you can see here they lost a bunch of studies by kind of paring down the criteria. And here we have 57 events of hyponatremia in isotonic fluids versus 141 events in hypotonic fluids less than 70. And again, this only looks at 135 being our cutoff. But even with that, you can see it still overall favors using isotonic fluids. And then because we cut out some more studies and kind of pared down the amount that we were looking at, it did bump up the variability to 18%. But again, our p-value doesn't show any significance, so we're still okay with that. It's under 25%. And then here is the same plot that we looked at the first time, but they took the value here and made it 130. So they said 132, 134, we're okay with that sodium, but we want to look at if it goes even lower. And then by just making the criteria even tighter, we lost any variability. So now we're looking at a better effect. And you can see what happened is when they did that, it cut out a few of these studies. And this one that was always sitting over here on the right side got dropped because it couldn't be estimated from the 130. But you can see even more so it favors this result over here. Yep. All right, so now we'll get into basically what the results actually showed for their guidelines. And your relative risk of mild hyponatremia was 2 times the risk compared to isotonic fluids. And for moderate hyponatremia, again, being less than 130, was 3 times the risk. So your risk persisted regardless of age. If you were medical versus surgical, if you were ICU or general peds, that risk still stayed there. And some studies even played with the fluid rate, saying if we put you on half normal and you were drinking some, or half maintenance and you were drinking some fluids, any adjustment of the rate, that risk still stayed the same. In post-op surgical patients, they had a risk ratio of 0.48, kind of favoring isotonic fluids to reduce your risk of hyponatremia. And ICU and general wards patients also had a reduced risk with normal saline. So the number needed to treat was to prevent hyponatremia was 7.5 across all patient populations. Obviously, we don't use half of a patient. You don't put like one leg on fluids and the other one not. So that was, you always round up, so you round up to 8. So you treat 8 patients, you avoid 1 case of hyponatremia, as long as you put them on normal saline. And then for moderate, less than 130, it was 27.8 or 28 patients. So the number needed to treat, this is the number you have to treat to avoid 1 adverse outcome, with our outcome being hyponatremia, and you're always rounding up to the whole number. A little epidemiological review for the medical students. This is the equation here, is 1 over the absolute risk reduction. And then your absolute risk reduction is looking at the risk of 1 outcome with your intervention versus the risk of the other outcome with no intervention. So again, this is the study, or this is the equation here, and then it's just 1 over that for your step and board exams. So continuing with your results, the reason they cared about 135 to 130 is extrapolation from the adult data showed that even asymptomatic mild hyponatremia that wasn't really getting picked up on or causing any problems was associated with independent risk factor for mortality. It also increases your costs in your hospital stay if you go chasing electrolytes, chasing numbers. So that's why they use that as our outcome. Some other adverse outcomes that were not looked at in this study was hypernatremia. They showed no increased risk of hypernatremia, but they did have a very large caveat in the guidelines saying this doesn't mean there's no risk and you should still keep an eye on it, but there wasn't enough evidence for them to even make a good quality statement. They just said needs a little more investigation, needs more follow-up. Also, another risk being hyperchloremic acidosis. The 150 milliequivalents of sodium in normal saline is there, but it also is matched by another 150 milliequivalents of chloride. Only 1 study actually really looked at or evaluated this, and it had about 60 patients, which compared normal saline and quarter normal saline, which demonstrated on the normal saline group a pH change from 7.36 to 7.32. And then in the quarter normal, it was 7.36 to 7.38 while they were on their course of maintenance fluids. There was no reported changes in the bicarb, and a majority of studies never appreciated a good appreciable acidosis, but they just kind of gauged it with bicarbs as they did their electrolyte evaluations. So again, they said we can't make a good quality statement on this. There hasn't been enough evidence. We recommend more studies go into that. Also, fluid overload being a risk that they identified, and it said it was not distinctly evaluated. So again, they can't make a good statement. There's not good evidence for it, but they said use clinical judgment and we think investigation is required. So now we dig into the critical appraisal. It's a little different than our other CAP forms, but it kind of gets us the same point. So is the clinical question clear and comprehensive? We said yes. The main concern was the use of hypotonic fluids for maintenance IV fluids and our outcome being hyponatremia, and that was fairly well described throughout. And then is the recommended intervention clear and actionable? It's pretty straightforward. We said yes, don't use normal, half normal, use normal saline or plasmolite. Again, they didn't make any recommendations for using LR. But some of the adverse effects were not necessarily studied enough. They recommended on a lot of them that needs further distinct intervention. We need to look at it ourselves. But the only one they really looked at was hyponatremia. So is the alternative clear? Yes, obviously. The alternative is don't use isotonic fluids. And again, the extraordinarily long list of exclusions is who you could still use those on. And anyone is 28 to 18 years, could get normal saline as long as they've been previously healthy and they don't have large diarrhea. And were all relevant outcomes important to the patients explicitly considered? I said no for this one. Hyponatremia is the main goal for monitoring with this intervention, but everything that we just went through, the other things that they mentioned as possible adverse effects, like fluid overload, they weren't adequately investigated to provide information on the prevalence with the new kind of fluid management or fluid guidelines. And was the recommendation based on the best current evidence? For this, we said yes. It's 2013 to 2016. They used multiple searches through 3 different databases, also looking at other meta-analyses. So they did take, I think, a large amount of the data that's out there for a relatively new guideline or new recommendation. And are the values and preferences associated to the outcomes appropriately specified? This one asks basically if you assume or to look into the kind of the patient's preference. And I can't say I've ever walked into a room and asked the patient's preference on which IV fluid they would like to be on.
Oh, but maybe there's a cost difference.
That's true.
Maybe the patient wants the cheaper IV fluid.
the less salt, the less the price. But they definitely did not make any mention or ask the patients which one they wanted to be on. So chances are they would defer to us and say, you're the doctor, you pick the fluids, but it was not explicitly explored or told. So.
Oh, interesting.
So, maybe preference.
They may have a preference.
Large amounts. All right, and then the authors indicate the strength of the recommendations. They use the United States Preventative Services Task Force system, the kind of ABCD. There was a table in here when I had it last night, and it was missing. Yeah.
It's on page 5.
It is. But they graded it with grade A being kind of the strongest for them. Kind of scroll over here. So like Dr. Doty was saying, it's on page 5. So they describe the level A as strong recommendation. So they definitely recommend for our studied patient population using isotonic fluids. It was well-designed, well-constructed trials. Meta-analyses was applied up to a broad range to our applicable population. And it was an independent gold standard of studies, which we used randomized control trials. So those were good strength to all form this grade A recommendation. Oh, there it is. Okay, excellent. That's kind of what we went over. And then further, is the evidence supporting the recommendation clearly understood? Hopefully you have a base understanding of the forest plots now, and they're pretty visually easy to read. You kind of look which side of the line, yes or no. And all of them, even when they played around with the parameters, were all leaning to hypotonic fluids, or isotonic versus hypotonic fluids. There was a supplement added which has all the forest plots if you really want to dive down into it. And then was the influence of conflict of interest minimized? I said yes and no for this one. The committee was made up of a broad range, so that was good. They had lots of different specialties, but the study was started kind of by the AAP, backed this formation, the study, made the subcommittee, so that potentially could lead to some bias. And then, in theory, if there was large groups of practitioners opposed to the AAP, I haven't met anyone yet, but they would have obviously been excluded from the subcommittee, leading to some bias. As for minimizing the rest of it, everyone else had to make any disclaimers or disclosures that was sitting on the subcommittee. So bottom line, there's increased risk of hyponatremia when you're using hypotonic maintenance fluids. This is compared to isotonic maintenance fluids. And can I apply this to my patients? I think anybody that's been on the inpatient hospital service would say yes. Obviously, it doesn't apply to everyone. We had that list of exclusions, and many of us are already using the D5 normal saline with 20 of KCl for maintenance fluids on the floor. And again, I think, like Dr. Dunsmore was saying, if you have a central line, you're getting a ton of fluids, you will probably fall into one of our exclusion lists if you're like an oncology patient or something like that. So some critiques of the guideline. They didn't really delve into the adverse effects like we talked about. They only looked at hyponatremia and basically chalked the rest up to kind of needs further study, needs further investigation. Going through the guideline, they talked a lot about their meta-analysis, but they never really, they brushed over the details. It wasn't as explicit as if they had published the meta-analysis themselves. There was more talk on the guideline and the evidence. So publishing the actual meta-analysis or being a little more thorough would probably help out. And then no mention was made of increased fluid rates. They only talked about decreasing the fluid rates. So they never talked about adverse events if you're doing 2 times maintenance, 1.5 maintenance, if that changed anything. They just talked about if they reduced it, it didn't change it. And then kind of their summary statement was the AAP recommends that patients 28 days to 18 years of age that are requiring maintenance IV fluids should receive isotonic solutions with appropriate potassium and dextrose because they significantly reduce the risk of hyponatremia. Here's our references, the study listed below, and then for some of the epidemiological things. And any questions so far?